45-year-old male carpenter, right-handed dominant, gradual onset right elbow pain for 6 months, no trauma, worsened after heavy hammering and drilling, aching pain on the outer side of his elbow, sharp pain with gripping, twisting, lifting, pain radiation down the forearm, minimal relief with ibuprofen or icing. So just what is this diagnosis? This isn't a trick question. Yeah.
Double hurts.
Yes.
Lateral
Yes. That's it. That's what this is. Lateral epicondylitis is what we call it in the I guess when we code it, because there isn't a lateral epicondylosis, but this is at lateral epicondylitis, or what do we call it? Tennis elbow. So this wasn't a trick question or anything like that. So I guess my question for you is, because I don't know what each one of you do for this, so how do you secure this diagnosis, and then what do you do with it? Also not a trick question. Because I've never been a physical therapist before. I've never been a chiropractor before. I've never been a surgeon before. So this is open for discussion. Yes. It's kind of weird though, right? Because we all treat this probably every day or pretty much any day, and then we're like, I'm not sure. I know I'm doing the right thing here.
This presents probably the same way in everybody's clinic. Get pain with gripping and holding, especially carpenters, because they're swinging the hammer. Is this right hand? Yeah.
Yeah.
Yeah. Range of motion, strength. We want grip strength. We want to just make sure that there's not any neurological involvements. We want to clear head and neck. Have you landed on your head? I had a board fall on you recently, just to make sure that nothing else is happening. Sensation, and then you get right down to it. Extensor carpi radialis brevis. Do the test. Poke it. Does it hurt right there? And then
what's the test? You said do the test.
So usually it's just this. So elbow bent, elbow straight, and then just grip, just to see. Sometimes it's the middle finger, and I call it an overuse injury, and they just look at me. But yeah. And then if these are recalcitrant for a really long time, like over 6 months, they become difficult because, as you mentioned, tendinitis versus tendinosis, if it's been going on that long, it's really a physical change in the tendon's attachment. And sometimes we have more pain, like really superior epicondyle. Sometimes it's a little bit more of a radial head, and you have to just differentiate that. Is it a radial head issue? Is it posterior interosseous nerve? Right. Really, for us, it's a couple centimeters down press. If they get some numbness and tingling in the hands, okay, that's maybe something else we have to rule out.
Like what?
Nerve entrapment.
Yeah, like supratender syndrome or something,
yeah.
Like PIN, whatever.
Yeah.
And then what do you do to fix it? Anybody want to fix this one?
I think research shows just tendon loading, eccentric, and putting more tension progressively, getting more eccentric control in the tendon.
What is eccentric, in case somebody doesn't know what that is?
Yeah, eccentric's just loading it from a shortened muscle to a lengthened muscle. So lowering dumbbell weight down, or hammer curls, but putting tension on the tendon that's potentially just, if, like you said, it's not necessarily tendinitis anymore, tendinosis, so it's a damaged tendon. It needs to be strengthened. Tendons like tension.
Okay. Yes.
Super handy if one of our colleagues maybe has an ultrasound machine.
Maybe it could be.
Like use some imaging.
Because I usually only present stuff that bugs me. Any other insights into that?
Dumbing it down a bit, pain control, range of motion, and then strengthening. So you don't want to just jump into the strengthening aspect. You're making sure that you're controlling that pain.
Okay. So I appreciate all this. Yeah.
I mean, in essence, the tendon lengths have changed, and they're more shortened and tighter, which is why the first step for this should be stretching. So the first thing that we'll do is get them on a really strict regimen of stretching, where it's straight elbow, wrist down once the wrist is maxed, and we add each individual joint to get that full lengthened.
And that's even a provocative test, right? So that stretching test is a...
First thing I'll do is I'll have them go like this, just stop.
Yeah.
If I stop it,
yeah.
that's really like done, over.
Yeah, you kind of know what it is. then one more comment.
I was going to say, with the structural changes like that, where we need to like restore that tendon's resiliency and ability to take load on. It doesn't like to be stretched and pulled. It's irritable. So progressive loading with concentric and eccentric exercises, a way to kind of restore the load tolerance of that tendon.
Awesome. Okay, here's a hard question. So this patient comes into your clinic. What's your timeline? What's your, like, you tell this individual, we're going to do this for this long, and we expect it to be better. What is that discussion like?
So if someone comes in, it's been 6 months, you're going to get some sort of imaging, ultrasound, or that MRI, something that's going to be able to give us a more clear, definitive diagnosis, I think would be pretty appropriate if they haven't had that done.
Yeah. Do you have something, Ben?
Yeah, it just, sometimes if you have someone that's weak and painful versus someone that's strong and painful, I mean, progression may be a little slower versus one or the other. I think there's a little bit of a long game on this at times. If it's chronic, it's going to take a little bit of time, and it's a tough one. I often will have to involve sports medicine with this and work in tandem with that. But I usually, 2 to 3 months, you're looking at this, and then within the first 4 weeks, we're not seeing some good pain control. We may bring in, refer them to your clinic and kind of work in conjunction with you as we can kind of progress through the rehabs.
Yeah, you had one more.
The data states that some of these can take up to 2 years.
Yeah.
To improve. And I think whenever I say that, patients always put their head down and they're pretty serious. But a lot of that study that published that timelines basically talked about how if they are using their arm for activities, for example, mechanics, they're reaching in there, they're grabbing it, they're twisting, that activity they have to continue because that's how they live. But obviously they have to make some modifications. That's going to take longer because
Yeah.
they're going to continually re-injure it.
Yeah.
And so understanding their occupation and what they're doing with hobbies and different things like that's going to determine the timeline.
And I think in my reading and stuff like that on this, it seems like Europe and Australia are a lot more patient getting these things better than we are here. Because they're like, in 14 weeks, you may be like with physiotherapy. I love physiotherapy. You may be getting better in 14 weeks. And like, holy crap, that's a long time. We get it better way faster, or we don't. So just an interesting, like, simple thing that we're seeing all the time. And these next few slides, just like we've discussed this already. And they talk about in here, regardless of study, if it persists more than, right here at the bottom, consider corticosteroids or PRP injection. Anybody injecting steroids in this? You do?
Rarely.
Yeah. So I just don't inject steroids. Why don't you use it very often?
Well, the whole point is it's a inflammatory condition that's trying to repair and heal itself. There's two thought processes there. Number one, if you make it feel better, then go back to using it just like as before, and it doesn't change anything. So you're masking the symptoms. And then two, if it's trying to heal itself and you're preventing that healing process, it can actually make it worse.
Okay. So my last set of boards I took, I just had to recertify in, I think, 2019 for sports medicine, and there was a question in there. You have this case, and the corticosteroid and the PRP was both on there for an answer, and asked you which one should you do, and the answer was actually PRP. When I did a residency, I did it in 2009 or fellowship. It was still, like, in my world, kind of not okay to use corticosteroids on a tendinosis. Tendinosis was a new term back then. And so, wait a minute, are we sure we want to be using a steroid on tendinosis? So I kind of, I guess, grew up in the world of not using them, but a lot of my mentors use them all the time. And I'm not saying it's evil or not evil. I'm just saying there may be reasons not to be using as many steroids on load-bearing tendons, especially directly into the tendon. And we see that with rotator cuff repairs. If you've had a steroid injection into the tendon, your rotator cuff repair has a less likely chance of being as good as the non-steroid used rotator cuff repair. So just something to think about. Does anybody else? I don't know everybody in the room, but does anybody else do injections? You said Dr. Pitts. What is your job? I don't.
Chiropractor,
Okay.
ozone injection.
Okay. Would you do an ozone injection in this?
Yeah.
Okay. All right, so this is just kind of the continuum of tendinosis. We kind of made this up, and you can see on the left side of the screen, the bright pink side is kind of like the tendinitis side of things. So itis would be the first 3 to 6 weeks of acute inflammatory reaction, and it's really amenable to treatment. So it treats really well in the tendinitis phase. I don't see tendinitis. Like patients don't come to me with these really acute things. I usually see them after the fact, after everything else has been done. But you can see that rice may help here. Physical therapy helps here. I'm sorry, this is an old slide of mine. I didn't put chiropractic on there, and it's not because I am excluding anybody. It's just I didn't get it on there fast enough. And the older I get, my PowerPoint skills are getting worse. Eccentric loading, ASTIM, Graston, nitro patches, that's kind of a thing that we used to try, which would increase blood flow, cause vasodilation. Also has a lot of side effects in healthy people, like low blood pressure and headaches. Not tons of research on that. Tenotomy, that's mean we poke a bunch of holes in it, either with a needle, a dry needle, a bigger needle, or a 10x device type setting. PRP, and then the 10x one. So those are all kind of the possibilities with the spectrum of tendinosis. And everything this day has a spectrum. So if we have anything where there's a spectrum in which a thing exists on, and we just we chalk it all up to tendinosis, or tendinitis in this case. Once again, this is just kind of like the process of tendinosis is on the left side of the screen, you have a normal tendon. On the right side of the screen, you have a tendon tear. And somewhere in between is everything else. There's tendinitis, and then there's everything else. And the further on the right you get, the more disorganized tissue you get. So there's more disorganization of tissue, there's fraying. I explained to my patients like a frayed rope. You get some of it, you don't get all of it, but the tendon is still strong. It'll still bear weight and do what you want it to do, or most of the time, but it's gonna hurt more and more the more to the right that it gets. There's a couple studies, PRP versus corticosteroids, and I love every one of these studies. PRP may be preferred for sustained symptom relief. So the marks on all these studies are like 4 weeks, 3 months, 6 months, 12 months. Which one, at 4 weeks, which elbow is going to be feeling the best? If you inject corticosteroids versus PRP. Yeah, the steroids for sure, but which one's better? I mean, like if you actually did a biopsy of the tissue and you looked at it, which one's actually better? And so a lot of things we use steroids in. Is it a huge victory? If you get like pain relief for 3 or 4 weeks, yes, it feels nice for the patient, but it's a short-term victory, long-term loss. Is what you're looking for. And if a person actually believes you got them better with that steroid and they come back 2 months later and want another one, you're like, let me explain to you how steroid works. Like it's actually not better. And that's not all the time. Sometimes we get lucky, we put a steroid in there and like, it's totally better, it healed it. Awesome, we'll take it, let's not ask questions. So all sorts of these studies, but they all show in the short term, corticosteroids, it's better. Short term meaning 4 weeks or less, long term PRP. And this one just showing that PRP is good for ligaments and tendon injuries. Pretty broad meta-analysis. So I wanted to show you a bunch of videos. And I'm going to stop this video and restart it because I want to show you what we see in real time. And this is following, someone mentioned MRI. So this is a, let me point out some structures to you. This is the most superficial tip of the lateral epicondyle, the bone. We cannot see past this bony interface, so any gray beyond this interface is just artifact. So this is the cortex of the bone. This right here is the radial head, annular ligament on top, and then the slope of the lateral epicondyle comes up to the tip of the epicondyle. What's important here is the first 50% of this slope, you can see this hump right here, right? I hope you can see this hump. You see what I'm seeing? So that hump is about 50% down the slope. So the bottom 50% is radiocollateral ligament. So this is radiocollateral ligament, and this is common extensor tendon at the top 50% of the slope. You can't oftentimes identify the ligament versus the tendon because they're collagen, they lay on top of each other, so there isn't really a separation there. But we can see that radiocollateral ligament coming off the radial head, inserting onto the lateral epicondyle, and everything above it being common extensor tendon. This is a needle coming in to the common extensor tendon, but this was called mild to moderate tendinosis on MRI. And this is the funny thing about laminar tissue, like collagen. It lays really flat, and there's like if there is a potential space in there, we don't see it on static imaging, not even on ultrasound. And so in my clinic, or I think it's not just my clinic, I'm not special to this, but we'll do a diagnostic lidocaine injection or even marcaine injection, and we'll just ask the question, hey, if I can make your pain go away, this is probably your problem, because some people describe this pain as like from here to here, and they don't believe you that it's like coming from here. And so if we can block it, then there's a little bit of buy-in to it. And so this is just injection of lidocaine, and you can see that this delamination opens up. So this is actually a space. We've created a space, and we didn't create the space, we just open the space with a little bit of volume, and it creates a partial thickness tear. So we just called this an intersubstance partial thickness defect of the common extensor tendon. But it's delamination, so it delaminates along the length of the fiber. So I had a rope going from the ceiling to the floor, and I grab that rope and separate it in this direction. This is what we're seeing here, not the rope is cut. There's cross-linking that occurs in the tenocytes that has been disrupted. So now this tendon is sliding on itself and also creates a lot of pain. So kind of an interesting situation. So we're going to kind of work through these slides. How do I have to go to that one? Okay. And so this is another picture of that tendon. We can see the hypoechoic nature of the tendon. Let me play it again. And I'll pause it there. So the tendon right here is thickened, it's hypoechoic. I wouldn't call this anechoic. Anechoic would mean a defect or a fluid-filled area, but we see blood flow in the tendon. Question, is blood flow normal in a tendon? No, it takes months to develop. And this blood flow starts from the outside and moves to the inside, growing perpendicular to the pull of the tendon. And with every little vessel that grows, you have a nerve that grows with it. And so you have this structure that's growing perpendicular, so when you pull on the tendon, your pain is actually out of proportion to what's going on now, because you're stressing a nerve every time you pull on the tendon. Hence, people just like hurt all the time with this, maybe out of proportion to what's going on. So this is a sign, this is called neovascularity, that this is really old. So someone comes in like, I did this 2 weeks ago. No, you didn't. This is months that this has been going on. But yeah, this is called neovascularity. And we'll see that oftentimes in the setting of chronic epicondylosis. Once again, neovascularity, just you see blood flow inside the tendon. And you have to use your setting on your ultrasound should be low flow Doppler on that to be able to see it. And I wanted to show this one. So this was a patient who had lost a lot of weight, started taking growth hormone, and was feeling fantastic and was lifting so much weight. And we know that with growth hormone, muscles increase size, tendons don't get strong enough fast enough. And so he got a steroid injection because he wanted to feel great and lift weights and do deadlifts and everything into his lateral epicondyle somewhere, non-guided. But you can see his common extensor tendon looks like Swiss cheese now. So this is a hole, this is a hole, this is a hole. I'm gonna pause it and we're gonna like go back a little bit further. Just all this stuff opening up, but I'm gonna progress it a little bit, then I'm gonna stop it right there. So after the description I gave you in the first video, what is this hole in? What is this structure? Radiocollateral ligament. So now he has a defect in his radiocollateral ligament. Whether that's related to steroid or not, I got no idea. But if you drop a needle in to bone, this is not very deep. I mean, you're 1.5 centimeters, so you're not really deep when you start injecting. Because when I was taught, you just drop it in on a bony part and inject. This actually probably penetrated the radiocollateral ligament, and now he has actually a defect in his radiocollateral ligament, which brings up a kind of interesting point. Of all those tennis elbows recalcitrant to treatment, 30% will have a defect in their radiocollateral ligament. So it makes it even harder to get better. And in this case, we can see that there with injection of, in this case, lidocaine. So all I wanted to see is how extensive is this guy's defect in his radiocollateral, not his ligament, but his common extensor tendon, and now he has a defect in his radiocollateral ligament. It's a partial thickness defect because we can actually test the stability, and he wasn't gapping or opening, so this wasn't a full thickness tear, but nonetheless a pretty extensive, crappy situation for that guy. So this is once again, just showing those defects that exist in that tendon. And let's see what this one is. Okay, this is interesting. So when you're putting together a study, there is, to date, there's no, like, unless you guys may know something different. So if I make a generalized wrong statement, please correct me. I don't know if there's a grading system for lateral epicondylosis or lateral epicondylitis. Like, this is like a mild, moderate, severe type situation. I would call this a severe type situation. And I'm guessing if we send it Dr. Pitts, do you want to do a surgery on that tendon complex? Like, there's like nothing to anchor crap to. Like, it's like what do you do in this situation? And the PRP studies don't say, hey, this is a really bad tendon and these are the outcomes. There's all comers in those studies. So in this case, if I were to put an injectate into that, a liquid, we'll call it like a very not very viscous solution into there, I fill it up, it just comes out. Like, it just leaks out into lots of other places. So yes, the platelets would be good. Dry needling or needling could be really good for this, but I'm kind of left to act like, what do we do for this? And so there's a couple of sources of stem cells that we're allowed to use in the United States that don't really have FDA approval or not approval because there's body components. So in this case, I take adipose, so I do a little mini lipoaspirate, and then I take platelets and we inject them at the same time. And you'll see this right here is the platelets and fat filling a space and not leaking out. So now we have a space occupying thing that we can scaffold through. And it does a pretty good job. You can see it leaks all the way down into the radiocollateral ligament. So in this case, where it's like Swiss cheese, if I were to sell, because PRP is not covered by insurance, if I were to talk to this guy and I say, hey, yeah, we do PRP on this because it's in the studies it works, he's going to be very unhappy in about 3 months when nothing happened. If I told him, dude, we could do PRP, it's going to be like 6 treatments, he's going to like, that's crazy. Like, because I'm not comfortable telling him I can get it better with 3, because that is a hammered tendon. And so with adipose, we can usually get it done in about 1 on these tendons. And so that makes people feel a little bit better. And as far as timeline goes, it's also, the way I describe it, I don't even know my timeline in here. Oh, we're just almost done. As far as timeline goes, I would never tell this person, you're going to be better in 3 weeks. I would tell him with physical therapy or with chiropractic care, you're looking at 3 to 6 months to be like, you go through a day and realize, I didn't think about my elbow today. It's going to be a long haul. This is just a left lateral epicondyle, once again injecting into that area. And now we have separation, we'll play it one more time for you, of the radiocollateral ligament and the common extensor tendon. You'll see as this fluid comes in, this tear is only in the common extensor tendon and does not involve the radiocollateral ligament. You see a separation of those planes as that occurs. And you can see, in this case, I'm moving the probe from anterior to posterior, so that defect tracks. Like, if I bleed the first part, that's a small tear, and if I move posterior, it goes all the way through the entire width of the common extensor tendon. So once again, kind of a bigger thing than we thought was possible, but once again called moderate tendinosis on MRI, because we don't see those potential spaces. And just, that's injection of PRP in that same defect. You can see the PRP swirling as it comes in. You'll see it swirl in this area, but if you play it long enough, it kind of bounces around and squishes out, so it doesn't like contain its space very well. But when I do those procedures, I needle a lot. So I'm putting lots of tracks through the tendon in order to basically express proteins for the platelets to bind to. Otherwise, I mean, they're not magic. They got to somehow have a signaling pathway into that region. So there's a lot of needling involved at the same time. And I'll just wrap up. I got lots of those videos. If you want to see them later, I can play them. But so as far as post-injection instructions, this pain is, has anybody had this procedure done on their elbow before? The pain following this procedure is horrific. So it's just like the patient goes home, they'll call you 3 hours later, you ruined my elbow. This is the worst pain I've ever experienced. Every time they move their fingers, they're like dying. And so I put them in a wrist brace and I tell them, you're going to have this thought that Dr. Chappell just ruined my elbow. And when you have that thought, I want you to recall this conversation that we're having, because I don't want you taking anti-inflammatories for it. And it's going to last for 24 hours, and then you're going to be okay. And that's about the extent of the conversation. And so we give Tylenol for discomfort. We have them start therapy about 5 days following the procedure, because the acute inflammatory cascade lasts 3 to 7 days, and they're pretty solid after about 3 days, and they can start their range of motion and stuff. But I just wanted to give you, more than anything, the take-home message is, just like anything, there's a spectrum of which everything exists on, and it's really nice to know how bad something is before you give a consensus on, you should expect this and be wrong. That's the worst. And they come back, you told me this, and well, occasionally 5% don't do that. You must fall into the 5%, and that's a terrible conversation. But
some of the research that we follow indicates that moderate setting of ultrasound increased collagen deposition in animal models, and so for us, for tendon and ligament repair, we like to do low dose ultrasound over that area. My question is, if you've injected that, should we be doing ultrasound? And
yes, anything you can do to increase blood flow is going to be great.
I just want to make sure we're not going to disturb the bed that you've sort of
and
the matrix there.
What I didn't go into is actually the procedure itself, because there wasn't time for it, but I break those neovessels when we do the procedure. So we do we just basically do a high volume image guided injection to separate that plane where the vessels come from and where they're going. And so we sever those neovessels on the way in. And so whatever you can do to reestablish correct blood flow pathways is going to decrease pain very, very efficiently. So you can get pretty aggressive with it pretty fast. And in wound healing, if you think about it, so say you sew up, skin after a total knee or something like that. 14 days later, you can't pop that open. That's a lot of collagen deposition. That's a lot of strength added in only 14 days. So the same thing's happening in that tendon after we offend it with platelets or stem cells or whatever else. You're not going to break it open. It may hurt a great deal to move it around, but they've laid down a lot of collagen in those 14 days. And in fact, after 21 days, it's now remodeling. It's not even in the deposition phase anymore. And so now you're in a remodeling phase, and remodeling takes up to a year. So some of these can go on forever.
I love that. Thanks.
Yeah. Any other thoughts? Okay, thank you.